Everybody for joining us today. Since our last briefing, we've received news that the FDA has authorized a third COVID vaccine, and that for people in phase 1B, tier 3 are now eligible to receive vaccines starting on March 15th. Now again, that FDA authorization is an emergency use authorization for COVID-19. So today we'll talk a little bit about both of those developments and how they might impact your plans or your loved ones' plans on getting vaccinated. So let's start today with a little bit about vaccines. And so I know there's a lot of questions out there about the differences between the vaccines and everybody's thoughts on this term of efficacy. And so we thought we'd go through a little bit about what they are and what it means, and at the end of the day, does it make a difference which vaccine that you receive? And so, as most people know, the Pfizer vaccine and the Moderna vaccine are what are called messenger RNA vaccines, or mRNA vaccines. Whereas the Johnson & Johnson is a little bit different, but it uses sort of the same sort of theory. It's based on genetic manipulation of an adenovirus. But at the end of the day, they all do the same thing, which is they trick your cells into producing a protein, which then your body builds immunity against. And so no actual virus is used. There's no potential of getting COVID from the vaccine. It's really an ingenious way of producing immunity in the human body. So a couple of things about efficacy, and I'll talk about that here in just a second a little bit more. But there seems to be a lot of debate, or at least conversation about these efficacy numbers. So the thing to keep in mind with the efficacy numbers is that they're measuring different things in the different trials. So the mRNA vaccines had different primary and secondary endpoints in their trials than the Johnson & Johnson vaccine did. The second thing to keep in mind is they were done at different time periods. So the Pfizer and the Moderna vaccines were done earlier on in the pandemic, where the Johnson & Johnson was done later on in the pandemic. And so why is that important? So clearly there were more cases out in the community when the Johnson & Johnson vaccine was going through trial. And the third piece is the different populations that were being included in the trials. So they were much different in the Moderna and the Pfizer, not much different, but they were different enough than compared to the Johnson & Johnson trial, which did have a population of South Africa in there. And so the reason why I bring that up is the environment was much different doing these different trials, which can account for some of the reason why these numbers look different. But it doesn't mean that one is better than the other. They all provide very good protection against COVID. They all provided very good protection against severe disease and against death. And so when you take all of that into consideration, there really is no difference between all three of those vaccines. A couple of other things which we've highlighted here: number of shots. So the 2-shot regimen for the mRNA vaccines versus the single shot for Johnson & Johnson. And then some of the other side effects, which are pretty consistent across all of the different vaccines. And so what people frequently, and so I'm just going to really briefly talk about this efficacy. Efficacy really is a calculation, and it's a very complicated calculation that the trial participants or the trial researchers perform. And so they're not equivalent one to the other. Although it's a number and people like to look at numbers to compare things, these are a little bit different. It's not like comparing, batting averages or things like that. This is a very different metric between the different vaccines. That have been administered in Region C. So as you can see here, our total doses that have been administered are 448,460. Now that number fluctuates. It's going to go up as each day continues on. Now we've broken them out a little bit here into our first dose and our second dose series. So as you can see, obviously there's going to be more first dose than second dose since there's a time lag. Around 300,000 of first dose and around 160,000 of second dose. And of course that second dose will increase and first dose will increase as days goes on. A little bit now about prioritizing population. So there's been a lot of discussion as well about the tier 3 versus the tier 2 populations, as well as what we're going to be focusing on until we can get through a lot of these different groups. So just to put it into a little bit of context, the reason why we're very concerned about this 1B2 population and why we're focused on them is because when we look at the clinical results from COVID-19 exposure and sickness, these are what we see. Of the over 70% of people that are admitted to the hospitals within the task force, or actually this is a sample from one of our healthcare systems, over 70% met the criteria for those 1B2 populations. So that's greater than 65 and anybody between 18 and 64 with one of those health conditions. So the vast majority of people that get sick enough to have to go to the hospital fit within that 1B2 criteria. So really important for us to protect them. Then the other statistic is a little bit more dramatic, but I think drives home the point. Greater than 50% of people who pass away in the hospitals due to COVID are greater than 75 years old. So again, when you look at the differences between, or the contribution that age and that chronic conditions have on who is exposed to COVID, it's clear that that 1B2 population needs the most protection. And so that is why the healthcare systems have been very deliberate about making sure that we're vaccinating this group of people. It isn't that the other people in tier 3 or even in phase 2 or phase 3 aren't worthy of receiving a vaccine or that we don't want to vaccinate them. But when we look at the data and we say who is most at risk for a poor outcome or from death from COVID, it is clearly this population. So we have to make sure that we have the majority of this population vaccinated before we can move on to the other tiers. Now, other vaccinators are working on plans for the tier 3 vaccinations, and that's a good thing. And in the meantime, we can, again, begin to organize those groups and make sure when enough vaccine becomes available, that then we can move swiftly on to these other populations. But right now, it's really important for us to protect the most vulnerable. And again, all of this is dependent upon the amount of vaccine that we get. We can only move as fast as the amount that we have. If we have more vaccine, then we move faster, and we can get to those next tiers and to the next phases. So speaking of that, we thought what we would provide for you here is an estimate on when we believe that we can get a majority of the patient population vaccinated. And so this again is from our analytics team. And so basically what we do is we look at the rate of vaccinations that are being provided throughout the area, so either from Region C or from the metropolitan area. And then we use a denominator of people that are greater than 18 years old, and we say when could we reasonably reach a penetration of 75% of people being vaccinated. And then you can come up with an estimate for a date. Now again, these are all dependent upon the rate. So if the rate goes up, the date moves up. If the rate slows down, the date gets pushed out. It's a fairly simple way of looking at it. So when we look at our rate of vaccination in our St. Louis MSA, it's a little bit different than Region C, and the reason for that is Illinois is a little bit faster paced than Missouri is. But at our current rate between the Missouri MSA, we're estimating that we can get about 75% of the population vaccinated around the end of July, which is a good, I think, approximation on when we could get those people vaccinated. Next, if we look at Region C, which again encompasses most of the eastern part of the state around the St. Louis metropolitan area, a little bit slower vaccination rate, so again pushes that date out a little bit further. But just doing all of the math behind it, it pushes us out around to the end of August. And again, that's based on current rate of vaccinations. If we get more vaccine, the number or the date moves further up in the calendar. So these, of course, are not exact numbers. These are approximations, and so we know that they're going to change. But we've been asked this question a couple of times by different people, and so we thought we would at least provide some rationale on why we're thinking the way that we are with our rate of vaccinations. So hopefully you found that informative. So we're going to move on now. Registering for vaccine, if you haven't already, we ask that you pre-register for vaccine. Doesn't matter which tier you're in, go ahead and get pre-registered. That's the first step in the process, get you into the system where we can then, again, begin to prioritize who we're vaccinating. And then when it's your turn, we send out invitations and get you scheduled. So you can register at the county health sites or at the health systems websites as well. And so those are listed here. And then lastly on vaccines, and then we'll move on to some of the other pandemic data. We always are encouraging our local medical professionals to volunteer at the vaccine site. So I was just at Jefferson County's mass vaccination site yesterday. Thank you, Jefferson County, for having me out there. It was a wonderful experience, was able to deliver vaccines to the citizens of Jefferson County. It's always a fantastic experience to be involved in things like that. So if you have the time, if you're retired or can donate your skills, please do volunteer for these efforts. I can just tell you that it's well worth your while. Okay, moving on now to our hospitalization data. So really good news to report today. So as you can see there, we're reporting 23 hospital admissions. And again, this is delayed 48 hours, but we haven't seen a number that low for quite some time. And so very exciting news. And our rolling 7-day average now is 36, so below that 40 person per day mark that we had marked as our red line. So continuing good news with our hospital admissions. Moving on to our hospitalizations, today we're reporting 234 patients in our task force hospitals that are COVID positive, and our moving 7-day average is down to 276 now. A little bit more detail on our numbers. Again, 234 patients COVID positive in our hospitals, 64 in our intensive care units, and 46 patients on ventilators today that are COVID positive. For our suspected COVID patients, today we're reporting 26 patients hospitalized with suspected COVID, 7 in our intensive care units, and 4 on ventilators suspected with COVID. Again, our good news slide, we discharged 44 patients yesterday from our task force hospitals, bringing our cumulative total to 19,520. And again, a shout out to all of our healthcare workers who've worked so hard throughout this entire past year to get these patients well enough to go home. So thank you to all of you. We still are seeing deaths, although they have also come down along with the other data. So today we're reporting 2 COVID deaths in our task force hospitals, and that brings our moving 7-day average down to 4. So continue good news with that. Now we are displaying all of our data, again, since we're only doing this once a week, so we have to put a lot of slides together to show you everything that's going on. So these are our modeling slides. There's not a whole lot more to report on this. It does seem to be tracking well with our current model. So the census keeps decreasing. You can see the difference there between the 2 models. And we'll take a look at this again on Thursday to see if we need to adjust the model, but it seems to still be tracking well. The COVID cases by county, again, no big differences in those epi curves from each of the counties, either on the Missouri side or on the Illinois side. So continued good news across our metropolitan area. And the same could be said across the state. We seem to be following all similar patterns across the state. Taking a look at our scorecard really briefly, we have gotten into the green zone with our total number of beds occupied with COVID, and we're getting close to the green area with our ICU capacity as well. So as you can see, once we break that 10% mark, we'll be in the green with our ICU capacity. Our rolling admissions, we already briefed this, it's at 36, so continued good news with that. The prevalence is down to now to 1.5. We're getting closer to breaking that red mark as well. And so as the cases come down, the prevalence is going to come down. And that reflects here with our weekly change in positive cases. We're at 17.6. It's ticked up a little bit, but that's because we had that slight bump from a week ago. So if we continue on this trajectory, that number will continue to improve. And then our positivity rate is down to 7.0. And again, this is from our hospital systems for diagnostic testing, so people that show up with complaints that are consistent with COVID. And again, we're down below that 10% mark, getting close to that 5% mark, all good news. And our transmission number, as you've heard us talk about, below 1 is good. Above 1 means continued transmission. We're at around 0.89 right now. Certainly has ticked up a little bit over the past week. Hopefully this will continue to come down as well. Okay, so we threw a lot of information out there, and I appreciate everybody's time and patience in letting us walk through all of that data. But to wrap up, I just want to reiterate that we're making some significant progress with vaccinations and hospitalizations, but we're still not finished with the pandemic. The federal government is projecting, you may have heard, that there'll be enough vaccine for every adult that wants one by May. And we are looking forward to the day when we will have supply that meets demand. And that's just a few months from now. And so, you know, you can say that the end of the pandemic is in sight, but we still have a ways to go. And we've seen in the past how quickly the virus can get out of control if we lose focus. And so we still need to stay vigilant. We need to continue taking those precautions that have brought us to this point and do everything that we can to keep that transmission low and keep the number of cases in our community as low as possible, so that those variants, that UK variant, can't gain any foothold within our community. So please keep doing all of those things that have got us to this point: social distancing, wearing a mask, avoiding gatherings, washing your hands, all of those things that we've said over and over again. And so with that, I'll conclude my remarks, and we'll take some questions from the media.
When Phase 1B Tier 3 opens on March 15th, will task force hospitals begin vaccinating people in that group, or will they wait until more people in the current phases have been vaccinated?
Yeah, so we're taking a very deliberate approach, much as we have when any of the phases have opened up. So when we moved from Phase 1A to 1B1 and 1B2, we made sure that we were completed with 1A before we moved on to that 1B1 and 1B2 population. And then even when we started with the 1B2, we also wanted to make sure we were prioritizing even within that population. So as I spelled out in some of our slides, there is varying degrees of risk even within those tiers, and we have to make sure that we're protecting the most vulnerable within our population. And so, as we've said many times before, it's exciting that more people are becoming eligible for a vaccine. But because we have limited quantity, we have to make sure that we're protecting the most vulnerable. And so we will continue to concentrate on protecting the most vulnerable while working in those next eligible populations into our vaccination plans and into our vaccination scheduling. So again, until we can get to where supply can equal demand, we're still just going to have to exercise a little bit of patience so that we can get to those people that are really at risk for severe illness and death to getting protected.
That concludes our questions submitted prior to today's briefing. Thanks for watching.